Good evening, doctors. On behalf of Hetero Healthcare, I, Dr. Prashant Khandeparkar, welcome you to this webinar on troubleshooting PCOS. Doctors, as you know, at Hetero, we market products in multiple therapy areas like in gynecology, dermatology, orthopulmonology, etc. We have very strong R&D support and we have developed many unique formulations keeping patient benefit in mind. Our endeavor is to develop products formulations which will improve patient compliance and ultimately clinical outcome. We have developed NSAID patches, reverse treatment patches for improving patient compliance. At Friends Art Division, gynecology, obstetrics, and IVF is an important therapy for us. We market products for vaginal health like Feminora, Pillitra. We have formulated and introduced a vaginal film containing lactic acid. In oral formulations, beside Diadrupal and other products, we market Mylotin. Mylotin is a unique nutraceutical for PCOS management. Mylotin contains myoinositol, dechloroinositol in the ratio of 40:1, chromium picolinate, and melatonin along with folic acid and vitamin D. But to speak more about PCOS and its management for nutraceuticals, I have the pleasure of welcoming Dr. Vidya Bandukwala for today's session. Welcome, madam.
Thank you.
Dr. Vidya Bandukwala is MRCOG, DNB, DGO, and FICOG. Madam is currently Director at Touch of Joy Women's Clinic and Fertility Center, consultant at Saket Maternity and Nursing Home, is founder member of Female Pelvic Pain Association, core member of Global Interstitial Bladder Pain Society, managing committee of Associate Fellow Gynecologist. I welcome Dr. Vidya Bandukwala to share her experience on PCOS with Mylotin. Welcome, madam, once again.
Thank you, and good evening to all. I must say that the topic which was given to me by Hetero Healthcare is something that we all know about, and it is nothing new. But still, when we see patients in our day-to-day practice, we always kind of humble and, some patients give us good response, some don't give us response. And overall, we know that the treatment of PCOS is nothing but lifestyle modification. So today, let's just speak about it in a more practical manner. And yeah, my slides are clear here?
Yes, ma'am.
Yeah, okay. So we are talking about PCO, which we all know is polycystic ovarian syndrome, and troubleshooting because each of these polycystic ovarian syndromes, they respond very different to all kind of therapies. Some of them respond very well, and some are so resistant to any kind of treatment that they literally make us as physicians confused in our day-to-day practice. So while we look at PCOS, let us understand that how complex this disease is. It's the ovary that is, dysfunctional, but what are its other issues that come to the different systems that are involved? So we have the physical involvement, wherein we see patients who have obesity. Primarily, we see about good number of patients, almost 30 to 75% of our patients who are PCOS are usually very obese. And there are a few of them who are absolutely lean. Now, this kind of gives us a very confused state to label the lean as a PCOS or not. So the criteria is very different and difficult to choose which patient to be treated in what category. Now, we also know that when we think of PCOS, we think of menstrual disorders, we think of their physical appearance, and we think of their USG morphological appearance. Now, these are the three criteria that was given by Rotterdam criteria. And we always think of these three when it comes to PCOS. Now, as we see that 1 in 5 women today, the numbers are just getting more and more because of the complexity of our living standards, our environmental factors. PCOS does have a genetic correlation, but more so it is the environmental stressful part of our life that we choose to stay in. In the criteria that we see, the most prominent that women come across, or the young women who come to the clinic, are the ones who have irregular pattern of menstruation. Usually they come with irregular patterns saying that I haven't got my periods for over 2 months now, or they get their periods regularly but very scanty, or there is a long gap and then they have a breakthrough bleeding with heavy flow. Now, all these patterns are seen in a typical form, but we cannot label every patient who has just menstrual disorder as PCOS. So what are the other things that we should be looking at? We look at their symptoms, their physical appearance. We look at the hair distribution. The hair distribution, which means that unwanted hair, especially the upper lip, the chin, the chest, all the areas which are male pattern, which is seen in a woman. Now, we all know that there is an idiopathic hirsutism. But keeping that aside, almost 50 to 70% of the women who have increased hair distribution have PCOS. We also know that 50% of the women can be diagnosed. Whereas 50% absolutely go undiagnosed till they reach the hospital for reasons such as infertility related, where the patient has been trying to get pregnant but has not been able to. And when we see her, we realize that, oh, this is the patient who has polycystic ovaries, not just by the ultrasound, but by her overall history, by her overall physical features, which she herself probably has not been able to find out. So we know that 50% reach us, whereas 50% don't. And this is where our awareness should be made to the general population. Though I think today PCOS has found its acceptance, that people know what PCOS means. In fact, we have youngsters coming to our clinic and saying that I am a PCOS patient. Very few of them really know what PCOS means to them and what it can do to them. We also know that almost 10 to 15% of the PCOS end up having a lot of fertility issues, and the reason being anovulation. So this is the patient who reaches and then realize that they have PCOS. As I also said, that obesity is commonly seen, but we also have lean PCOS. The crux of all these complex disease is what we say is the insulin resistance. Most of the patient, almost 70% of the patients have insulin resistance or hyperinsulinemia. They end up having hyperandrogenism. So we come, and as I said, 1 in 5 women in India suffer from PCOS. I think the numbers are only increasing as the years pass by. So what is PCOS? We know that in 1935, it was Steen and Leventhal who actually realized and picturized the whole PCO profile. And there is much more that studies that went on and to the criteria that we today look into. The condition that we morphologically look when we look at an ultrasound picture is that the ovary at least has minimum of 12 follicles. Now, why do we look at the follicles? Because they are patterned like a necklace in the periphery, and each of these range in the range of 2 to 9 mm, around 10 mm if you go, or the volume is around 10 mm. And we know that these are arrested, they are not fully matured. And because they do not mature, they do not release, and the patient has anovulation. And when we look at a fertility treatment, we are looking at this pattern of ovulation. We also know what are the complications that come along when we label a patient as PCOS. The complications, as I said, in the physical appearance, and these are so important for a youngster because of young girl having hirsutism, having eruptions in the form of acne, having obesity with a typical obesity over the waistline, increased BMI. They kind of have low esteem because of their body image. And they end up having a lot of depression and anxiety, which can lead to mental health issues. So it is so important to catch them when they are young, because these are the youngsters who probably will later on in their life land up with metabolic syndromes in the form of landing up with type 2 diabetes, glucose impairment, high blood pressure, cardiovascular diseases because of dyslipidemia, because of the over excess hormonal estrogen onto the endometrium, landing up with endometrial cancers, sleep apnea. These are all things that we have been seeing in the 4th or 5th decade. But why did we see it? And why do we see it? Because these were the ladies or the women who are neglected in their youngsters, who are not picked up and hence landed up here. So today, as a physician, it is our duty to kind of educate our youngsters who are picked up as PCOS. We have to educate them and let them know that in case they do not change, and the change is very simple, it just needs a lot of lifestyle modification, a lot of patience into doing that. But why should they should be doing that? The reason is the long-term consequences can be disastrous. So I think when we look at PCOS, we know that they have hyperandrogenism, which leads to hirsutism, which leads to acne, which leads to a different physical appearance, that is obesity. They have menstrual irregularity and a morphologic look of the ovaries. What are the symptoms that we are looking? We looked at the reproductive system, and the system involves the changes in the menstrual cycle. That means these patients, in fact, women who have PCOS or youngsters who have PCOS, they hardly have 2 or 3 cycles of periods throughout the cycle, whereas the normal range should be minimum 8 to 9. So we have to let them know that they need to regularize their menstrual cycles. What are the other things that we look at? We look at hair distribution. We look at their acne. Usually the acne could be overall on their face, even on the upper chest and on the back. They have a coarse hair distribution. Now, why do we look at infertility and pregnancy complications? Because we know these women do not ovulate and they will have fertility issues. So these are the patients who will come to us, maybe later having pregnancy issues. What is the metabolic features that we look? When I say metabolic syndrome, I mean that there is insulin resistance and we need insulin. We need insulin for our glucose metabolism. So these patients end up having glucose intolerance, impairment, and they end up with type 2 diabetes. They end up with dyslipidemia. They end up with dyslipidemia and the complications of cardiovascular system. They end up with sleep apnea. So all kind of issues are erupted just by the ovarian dysfunction. Now, when we come to the psychological part, as I said, that because of these symptoms not appealing to a youngster, they go into anxiety, depression, changes in their mood, and all leading to a poor quality of life and poor self-esteem. These are so important for a growing young girl, because this is the young girl who is looking forward to a bright future, but because of her changes in her body, she is unable to achieve these and ends up being in a mental disharmony. So let us look at what is the pathophysiology. We all know that environmental factors, genetic predisposition, changes in the gut, these are newer studies that are now coming into the picture, and diet and lifestyle. With the things that are changing in the country, the entry of newer food cuisines and everything, we are seeing our own young children are thriving on pizzas, on Italian pastas, and all these have high carbohydrate, high fatty diet, all leading to changes in the gut metabolism and in hormonal imbalance. So the reason that comes that changing PCOS is a very simple change that our children or our women need to do. But it is so complex, it is so difficult because the compliance is so poor, because they do not understand the pathophysiology of PCOS. We know that the diet and lifestyle change can do a lot of changes in the insulin resistance. It leads to hyperinsulinemia, increased insulin level, decreases the glucose. So there is impairment of the glucose metabolism, hyperandrogenism, increase in the testosterone and decrease in the sex hormone binding globulin, increase in the LH-FSH ratio, decrease in the FSH secretion. All these leading to the different symptoms that we see in the PCOS. And the diagnostic criteria, as I said, it is the Rotterdam's criteria that we look at. So we look at what? We look at the clinical and biochemical changes of hyperandrogenism. We look at the menstrual cycle. So it is the history that a patient gives. It is the ultrasound picture that we see. And it is the overall clinical features that we see. In fact, some of the women end up with acanthosis nigricans, a very thickened skin appearance that looks around the neck, around the breast creases. These are all typical pictures of PCOS, but sometimes they have severe pictures. What do you mean by hyperandrogenism? We all know that hyperandrogenism leads to an androgenic environment in the ovary and hence leads to anovulation. But what are its physical features? Leading to an increased distribution of hair in unwanted areas, acne as a male pattern, and androgenic alopecia. When I say androgenic alopecia, these are the features which are seen in the male, which a female experiences, those who have the typical PCOS picture. And these are the androgens that work on the pilosebaceous unit. So they usually have the temporal baldness, receding hairline, very typical features. Now, hirsutism is the growth of the terminal thick coarse. So as I've said that their coarse, the fine hair is replaced by coarse hair. And the treatment that we can give them is not just a gynecological approach, but we have to kind of have another specialty working in conjunction with us. We need another nutritionist, a dietitian who can help us with all the changes. So it's a multifactorial kind of a pattern and multidisciplinary approach in a treatment. So when I look at a hirsutism patient, I just don't deal with a patient as a single gynecological approach. We need to involve a dermatologist. We need to let our patient know that maybe the hair which is already present will not disappear, but at least the newer ones will not appear while they are on treatment. So compliance is very, very important in all the PCOS patients. Acne, as we know, that almost 12 to 14% of the women who have PCOS do have acne. And we know, we all see those in our daily OPD. Again, the alopecia, I won't go details into it because we have seen that it involves the loss, which is limited to the crown and just not just the frontal hairline. Ovulatory, we know that these women have a very long gap between their menstrual cycles. Some of them probably will have 2 or 3 cycles in and the best part is youngsters sometimes feel that it's absolutely fine to have 2 or 3 cycles in the year because it is so gruesome for them to, have more cycles. So they do not address it to their parents, nor do they address it to any physician because they are very comfortable. Oh, I didn't get my periods for 3 months. I'm most comfortable, but they do not understand the repercussions. So these are the young girls or these are the youngsters who need to be educated about the side effects of not getting periods on time. But as soon as these women start gaining weight or they have acne or they have increased hair growth, they will definitely may not reach a gynecologist, but definitely a dermatologist. And I would plead even the dermatological family of physicians to please work in conjunction with the gynecologist. It is just not a one department treatment. It includes a lot of multidisciplinary approach because these girls usually are they have a very low threshold for anything. So the compliance is so important. So PCOS takes its name after, we all know that when patients come, some of the patients actually come with a ultrasound picture and absolutely with a scary look as though they've, somebody has told them that they have cyst and it could be malignant. So we have to let them know that the morphological look of PCOS can be seen in adolescent ultrasound. So it is not the criteria to label them as PCOS, or it is not cyst, but it is multiple follicles that was labeled as cystic. So it's very important to speak to them. Again, Rotterdam criteria is always the criteria that we use to differentiate PCOS from other conditions. The prevalence is quite high among women with androgen excess. We do not know whether PCOS leads to hyperandrogenism or hyperandrogenism. So they kind of form a cascade and a vicious cycle that goes in, which we know that insulin, hyperinsulinemia, hyperandrogenism, PCOS. So they all go hand in hand, and we need to cut that. We need to cut that vicious cycle, break it, and then work on these kind of patients. However, from 8 to 25% of normal women and even 14% using oral also meet the. So I think we just don't need to go to one criteria, but we stick to the Rotterdam criteria of diagnosis. Now, what is the abnormal gonadotrophin? We know that when we look at the LH and FSH ratio, we know that when we are looking at androgen, it always comes as LH. So we see a reversal in the ratio. We see the patient with PCOS usually tend to have a high LH concentration as compared to the FSH. And this was usually taken in consider prior, but of course, things are changing as the research work continues with PCOS. So what is the insulin resistance that we cause? We know that the patients who have PCOS tend to have high levels of insulin, which are not acting on the tissues. So the glucose metabolism is disturbed, and hence the insulin is secreted much more to take care of that excess glucose. But in the bargain, they tend to be hyperinsulinemic and insulin resistance, and they tend to have obesity. So we have seen that picture. Most of the women with PCOS and insulin resistance are young and have ample of pancreatic B cell reserve. Consequently, they are able to generate a compensatory hyperinsulinemia to fight back, to deal with the excess glucose, but they're just not able to do that. And in the bargain, we get hyperinsulinemia and resistance. When I spoke about dyslipidemia, we know that obesity has its own issues, and this dyslipidemia leads to the metabolic syndrome in the form of creating a type 2 diabetes, cardiovascular episodes, sleep apnea. So in total, the high density cholesterol is on the lower side, but the low density is on the upper side, and there is a higher level of triglyceride level. Now, why is this very important? Because when we are treating these patients, all these aspects do play a role. And as we see the treatment profile, or we see the response of our treatment, we'll look at all the profile that goes hand in hand in PCOS. Now, how do we evaluate a patient with PCOS? Again, there are certain blood tests or blood investigation that helps us. So when we look at a young girl, we probably look at all her features of her basic profile. We look at her thyroid, because anybody who has obesity related things, we must exclude thyroid in her hypothyroidism. When she comes with menstrual disturbances, we must look at the prolactin level. And when we look at a woman, we also want to exclude PCOS. So we look at her glucose tolerance test, her lipid profile. Of course, endometrial sampling is not the test in the initial or for a young person, but of course, later on, when we see a lot of obesity, diabetes mellitus, type 2 diabetes mellitus, or high blood pressure, then of course, we must always rule out endometrial hyperplasia or endometrial cancer by sampling such patients. Serum testosterone, when we are speaking about hyperandrogenism and we are looking at a patient with hirsutism, and we know that there is idiopathic hirsutism seen, serum testosterone plays a role. The free and total testosterone is what we look at. Again, we look at other things, overnight dexamethasone, when we think of adrenals. So we have to have these kind of evaluations done. Now, we know that most of the young women do not realize that they are PCOS unless they go to a gynecologist where they are unable to fall pregnant, and that is when they are picked up as PCOS. So we know that infertility affects 40% of women with PCOS. So imagine 40% of the women with PCOS are infertile, and we know the reason is that they do not ovulate, and that is the reason of their fertility. So we know that these women, when they fall pregnant, they may also miscarry the pregnant because of the luteal phase defect. So these are important factors for us for our treatment. Again, the investigations are the similar thing that I just spoke about. Let's just move on to the next pattern. Now, when we look at the goal of treatment, now here is something that is very, very important. The goal is a complete overlook of the patient. We're looking at her physical characters, we're looking at her metabolic characters, and overall mental health, all going one in one. We cannot say that, oh, we're going to only treat the menstrual part of the PCOS, but we don't want to treat the hirsutism or the acne. No, they all go hand in hand. The minute you start treating them, they will start to show their response in all these criteria. And what is the most important criteria that we are looking at? We are looking at obesity and reduction in weight. The minute these women or youngsters start showing weight reduction, we will automatically see a change in their complete profile. So the first line of treatment, which was always spoken and which will always be, is the lifestyle modification. The reason being, our women are absolutely in different walks of life, leading the team, doing a lot of multitasking, and they're always in stress. Late hours of working, sleeping late hours, eating at odd hours. Now, this is where the body signals them where they need to take a step back and calm down and change their profile. And this is where the complementary pharmacotherapy will help them. So I would say that 70% of these women just need simple changes in their life. Nothing complicated, just simple changes. And we may just help them in just getting their menstrual cycle regularized. And that itself will put other things into control. So while I say regulation of the cycle, improving insulin sensitivity, reducing their weight, will improve this all goes hand in hand. It is not that one works, it is parallel. They work in parallel together. So how do we manage? We know that PCOS can be picked up as early as the pubertal age to the fourth decade of our life. And we know that there is hyperandrogenism, we know there is insulin resistance, and how do we tackle them? Now, we need to start with changes. Now, women who come with fertility problems, we need to work with the fertility. As I said, that when it comes to fertility, we see there are lean and we see there are obese patients. It's so easy for an obese patient to be counseled because we know all she needs to do is work on her obesity, get her BMI down, and things will settle down. That is the way we treat them. But what about lean PCOS? How do we talk to them? What do we tell them? But of course, exercise has a bigger role. It's all about being fit. It's not about losing inches and all. The metabolism that helps in a lean patient is also very important. The glucose uptake, even in a lean patient, is so very important. So our whole idea is not always about losing weight, but by increasing the metabolism in their body is what we should stress upon and make them aware of. And when they are not able to shift their weight, then we help them with the pharmacotherapy. We all know that we have prescribed oral contraceptive pills, which have anti-androgenic effect as well. There are pharmacotherapy in the form of metformin, myoinositol, and D-chiro combination. Now, what are these? These are again parallelly working with the conservative change in lifestyle issues. So they work parallelly and they help the patient to get the results. So it's very important to give them a precise diagnosis, especially in the extreme ends. So very young girls, very difficult to treat them because their compliance is very difficult to tell them to go on a diet because it's their age to eat the junk food as they believe. But just educating them, explaining them, and letting them know that what are the repercussions that will go in the later part of their life. I'm sure these young girls are smart enough to understand and become their own advocate dealing with their life. So they do understand, and if well explained and counseled, they do very well. Lifestyle therapy tends to be the first. I will keep pressing upon that. Pharmacotherapy is parallel to that. So in the pharmacotherapy, we know that we give the oral contraceptive pills, not just for the birth control part of it. It is always given in the menstrual regulation, but patients have to be told, because young girls, when we prescribe them oral contraceptive, they are very reluctant to take the pill. The reason being, many of the patients think that it is the only role of OC pill is birth control and the other roles are not known to them. So we need to counsel. Counseling goes a big way in treating PCOS patients, especially the adolescents to the younger pubertal age group. The ones who have fertility, again, they feel that if they lose 3-4 months in OC pills, then they will have difficulty. So you have to kind of explain to them that we are only changing the milieu, the androgenic milieu in the ovarian tissue, so that helps us to give them the treatment in the fertility part. So overall, look at them in both ways. Very important, as I said, always press upon lifestyle improvement, which of course give them an idea of changing their sleeping pattern, their eating patterns, and a regular physical activity. Just tell them that a 5 to 10% decrease in their weight will be all that is needed to make the first step or first move to the change and response of PCOS treatment. No specific diet. You can just tell them to moderate their diet and eat at the right time. Most of our youngsters like to eat late in the night and they have different sleeping patterns. It's just change in their overall profile that will bring the change in the PCOS and the response to us. Behavioral pattern, of course, you must have a goal set. You must give them a goal. You must tell them what is their weight, which is adequate or which is the right weight for their height. So BMI plays a big role in maintaining them. Self-monitoring, just tell them to be self-monitoring their own response and progress. I'm sure when these patients come in 3 months, they themselves come with a smile on their face because they come with saying that, oh, my acne is much under control. Of course, hair distribution is not immediately picked up, but with the treatment, with the dermatologist and all, they get a very good response. Now, when we look at a pharmacotherapy with lifestyle changes, we're looking at the OC pills, which has drospirenone, which has cyproterone acetate, which acts as an anti-androgen. All these pills do a lot of good response in decreasing the androgen levels. We also know now when we look at the two molecules, we look at inositol supplement, the Mayo and the D-Chiro combination, and we also look at metformin. Now, while we have metformin, which also has given us very good response, the intake of metformin has a lot of GI effects, and hence the compliance is very poor. Also, when we give a patient metformin, they always correlate as a diabetic drug. So it's very difficult for a metformin to be given to youngsters. So what is the other best option? The other best option is inositol, that is the myo-inositol and D-Chiro in a combination, in a physiological combination of 40:1. We know it has played a good role in insulin sensitivity, and it has given good quality oocytes and embryos in patients who have had IVF pregnancy. Now, I will bring a situation where I actually had a patient who went in, a PCOS patient, about 33 years old, who went for a first cycle. Everything went, we got good number of follicles and we got good oocytes, good embryos, but she went up to about 8 weeks, and with all the luteal support, she miscarried. And at that point, it just came to me that why not introduce her to some a dose of metformin or inositol, and take her through that pregnancy. And what we decided is, with her next cycle, we introduced her to myo-inositol, and believe me, she did well. The luteal phase also went well, and she carried her pregnancy. So probably it has a good role and we gave her much before. Also, there are patients who have IVF cycles going. It is better to start them before, not when they have the IVF, at least a month or two before, because that gives good quality oocytes. So what oocytes we get with the ovum pickup is what is more important, because that will give us good embryo quality, and that will also give us. But what I'm also saying is the luteal phase defect is also taken care when we give them myo-inositol. Lipid-lowering agents are usually given in the later part where there is a gross dyslipidemia and lipid abnormalities in a pattern that can cause cardiovascular issues. So what is the current gap that we are looking? As I said, very, very difficult to treat a lean PCOS. It's not just correcting the PCOS, but a lot of counseling that goes with that. We have infertility patients. We all know that some infertility patients do very well with just minor changes in their weight, minor changes in their lifestyle. But to get them to ovulate is a challenge that can confuse and create stress to even their own physician. So it is a very difficult. So getting them to the correct line of treatment is something that I would say it is customized and it is individualized. You cannot say that one PCOS treatment works for another PCOS. No, each one has to be treated in a different pattern. We have the obese. It's easy because we can counsel them to lose weight, change their lifestyle, and they do really well. What about those with high insulin? Of course, those with high insulin also work well. They work well with the parallel management of lifestyle modification, including the insulin drugs, the insulin sensitizers, I would say, and the hormonal imbalance, which we've already spoken about. Now, when we look at myo-inositol and D-Chiro, we are looking at the benefits. What are the benefits? They regularize the menses. Indirectly, they give the improvement in the oocyte quality That is very important. We look at chromium picolinate, improves the insulin sensitivity. We look at melatonin, improves the... So there are not just one drug. There are a number of drugs which can be given in combination because each has its role. And if we look at it separately, as we say that you must take this medicine, the patient feels like they are in a disease state. We cannot make our patients feel like they are in a disease state. We just need to say that these are the vitamins that are on the lower level, and we need to combine and give them to get a better improvement and quality in their response to the treatment. And yes, there is an ideal therapy which has a combination of all this. And if there is one, why not give it? So we are looking at myo-inositol and D-chiro. They are the group of inositol together. They come in the B complex category, which we have in our body. Now we know that there is a 500-fold decrease. That means in PCOS patient, we have seen that there is a decrease in the myo-inositol level. And that also gives us an understanding. The development is impaired because of the reduction of MI. Combined dose of MI, when administered, have found to show a lot of beneficial changes in the form of ovulation with good eggs, which means good follicles, good oocytes, and their pregnancy rate being higher. So definitely they have a substantial role in ovulation, and D-chiroinositol has a big role in the insulin sensitizing part. So they in combination, and the physiological ratio being 40:1 is definitely considered as the first line. And if you look at that, we always look at myo-inositol and metformin. As I said, compliance with metformin is low. So in case of such patients, myo-inositol plays an upper role, and recommended low dose is 2000 milligram of myo-inositol in a BID dose. So we have trials which showed that, 4-gram daily dose along with folic acid gave a much better this, because there was a better insulin sensitizing effect, and that helps the patient to ovulate and give good follicles, good ovulation profile, and good pregnancy rate. So these are the ratios that we are looking at. We know they are the same stereoisomers of inositol group. They're all insulin sensitizers. And what does MI do? It's the second messenger of FSH. And we know the role of FSH in a folliculogenesis. We also know that DCI, that is D-chiroinositol, is an aromatase inhibitor. We know that the physiological dose is 40:1. And we know that their overall role in not just the menstrual cycle, but it has its role in insulin sensitizing and its role in the acne and other things. So if we're looking at a complete metabolic and physical parameters of symptoms getting corrected with myo-inositol and D-chiroinositol. When we say of chromium picolinate, we look at its increase in the gut absorption. We look at its role in reducing hyperinsulinemia and hyperandrogenism. So as I said, that not just myo-inositol, but a combination of other drugs put together can help in the treatment profile of PCOS. It is better tolerated than metformin. We all know that metformin has its own GI complications, which patients are not compliant with. We have studies which have shown chromium picolinate with metformin. I do not want to go into details of this. Again, melatonin has its own this in the nuclear maturation of oocytes, and administration may be useful in the in vitro fertilization strategies with an improvement in the clinical outcome and overall pregnancy, take-home pregnancy, as I said. And we have melatonin with its trial that has showed its role in PCOS patients. And so we know that folic acid is given for all our pregnant and pre-pregnant patients with vitamin D3 as its this. So overall, when we look at PCO, we are just looking at not just the physical appearance that need to be brought to a change, but we are looking at the mental health of a patient, which is so important. And I will give in one example where I had this adolescent girl. She was in her 15 years, and she was preparing for her 10th grade, where she had gained a lot of weight and very typical male pattern look, tall girl with a big build and, acne and mustache, like a beard and all that. Mother came with panic and she said, just over 6 months, all these changes have happened. And it was so difficult because I couldn't have told her to, do some exercise because she was giving her board exams. It's so difficult to treat such patient, but I had to counsel her and I had to sit with her to give her that lifestyle change modification where I said that you need to study, but you need to keep your hours. You cannot do late night. You cannot, not eat at right time. And you just need to give 45 minutes of yourself or half an hour, 45 minutes, just to give just a complete, a physical activity in the form of walking or cycling and changes. But along with that, I needed to give her something for her menstrual irregularity. So I had to put her, and she was very reluctant to go on an OC pill. She was very reluctant. And I couldn't have even thought of giving her metformin. So what I did was I just gave her a combination of myoinositol and D-Cairo. And I said, just go on this for 3 months. 3 months, I just asked her mother to support her. I said, you need to help her because if she goes on like that, she'll land up with other issues. And all that I did was just counseled her. I put her onto a dermatologist and a nutritionist. And I said, just go with the diet that is planned. She was a very smart girl, a very focused girl. As we said, that goal setting was very important. And that is all I did to her. I just asked her to make simple changes in her day-to-day. Just organize yourself for your study time, organize yourself to go down for a walk, organize your eating habits and your sleep pattern. And believe me, in 3 months, which I looked through her, I seen a lot of changes. So that is the reason I said that in patients whom we cannot give a different combinations and who have a lot of reluctance and compliance in accepting other drugs, myoinositol and D-Cairo combination, along with all these chromium picolinate, melatonin, they help in the management of PCOS. We have these kind of case studies. We have patients who are infertile, who have anovulation, and we know that, these are PCOS. All that we need is a good ovulation pattern. And just counseling them, getting them to reduce their weight, changing their lifestyle pattern, and introducing a pharmacotherapy. Sometimes we need to put them on a course of oral contraceptives along with a myoinositol or a metformin combination or just plain myo can make wonders, because we have seen that. I have seen in my practice, and I'm sure you all have had patients who have given you good response. So while we have a drug which has all the beneficial effects that can be brought together in just one pill, I think the compliance is most important, because today patients don't like to take multiple drugs. They prefer everything to be in one drug, and they do not really have the time. I mean, today we as physicians, when we end up in some situation, we don't like to take multiple drugs. So why not have it in one? So I think if I look at PCOS, let us all look at PCOS is by taking the right history, diagnosing a PCOS at the right time, counseling them, and allowing them to have a change in their lifestyle, and just complementing them with the right drug, which involves all the beneficial effects, will go a long way. So when I look at adolescents, when I look at a woman who's, planning a fertility, this is what is important. So thank you very much.
Thank you, madam. Thank you, madam, for such a lovely session.
Yeah.
There are a few questions. I mean, it's really, some of the things we did not know, I mean, madam, amongst this group of symptoms, like, we classified them as reproductive, metabolic, and psychological, which are the most common group? Which is the most common group?
So when we look at metabolic, we are looking at glucose impairment.
Correct.
We're looking at type 2 diabetes. We're looking at hypercholesterolemia, increase in triglycerides. Now, these
metabolic syndrome.
Yeah, these are the ones which create sleep apnea. These patients have a difficult in sleeping pattern.
Okay.
So these have to be addressed while we speak to a PCOS. So PCOS is not just in the 20-30s. We are also seeing PCOS in 30s plus.
Absolutely.
And these are the ones who land up with metabolic syndrome.
Correct. And once they land there, the blood pressure is so simple. It's just have blood pressure. I mean,
so
simple.
Then it's a cascade. It just goes on and changes.
And
But
obesity,
the best part is these women, by just simply changing their lifestyle pattern, have shown a very good response.
I mean, there cannot be any condition where, simple change in lifestyle can make such a big
Yeah,
improvement. I mean,
yeah,
the patient that you described. I mean,
absolutely. Absolutely.
and in which group of symptoms does Milutin, like this type of combination work the best amongst? I mean, what I'm referring to.
If you look at my myoinositol, we all
Yeah.
know that it has major beneficial effect in patients who have hyperinsulinemia and
Okay.
insulin resistance.
The metabolic type.
Yes. So
Yeah.
I would look at an obese patient, because we know in
Oh,
obese
yes.
patient, insulin resistance is highest. And we know that insulin resistance causes obesity.
Yeah, yeah,
So
yeah. Correct.
these are the patients, we must definitely put them on myoinositol.
Yeah, yeah, yeah. Generally, how long you prescribe these formulations?
So ideally, you can go on for a good 6, 7, 8 months also.
Okay.
But the first 3 months is important, because this is where you see the changes that is happening. So while
And
you counsel a patient, you cannot say that this is for life or this
Oh,
is
yeah,
for
correct,
8 months.
correct.
So you start with a 3-month course. You ask the patient to follow up, and then we, of course, take that forward.
That's correct. And even they take for 3 months is a big time. I mean, really.
Oh, yes, yes. So I
People
told
drop
you, compliance.
antihypertensive drugs also.
Yeah, compliance is very important.
Yeah, yeah, yeah.
That's where the counseling goes.
And any adverse effects that you have seen, any untoward?
I don't think there is. They do have some GI symptoms, but as I said, that once
nothing,
you keep
nothing major,
continuously take it.
which will, I mean,
Yeah.
necessitate withdrawal.
Yeah.
Now, along with this, do you prescribe metformin, or metformin is prescribed, or this type of combination is
So as I
prescribed?
said, it is always individualized.
Yeah.
Now,
Okay.
when I say 3 months, and I see, especially in fertility patient, where we want her to ovulate. Now, this is the group of patient where the treatment can be a little different as compared to the one who are adolescents in pubertal age,
Correct,
or those who are
correct.
not interested in fertility.
Okay.
So they are two different individuals where we
Correct.
treat them differently. Now,
But
when
this
we look at, when we look
Yeah.
at getting a good quality egg, and we have put them in myoinositol and D-chiro combination, and we haven't achieved what we want, then of course a metformin addition makes
Oh,
it.
yes. Okay.
So as I
okay.
said, all depends on fertility and not fertility.
And yeah. If patients who require fertility, I mean, metformin, I mean, you do everything there,
Yes.
maybe some, other drugs also. And this is very risky, 1 month before IVF procedure, like we use probiotics. I mean, this type of things would be useful.
See, I gave you 2 scenarios where actually starting before can change the ovarian tissue milieu, the environment around the ovary.
I mean,
That
will
is
be
what we
great
want.
benefit.
We want the androgens to decrease. We want the change in that will help to get the quality oocyte.
And everything will be by natural way,
Yes,
I mean, the
yes.
diet.
So we
I mean,
started before,
the
but
nutrients.
by starting later is sometimes it helps in luteal phase defects.
Okay. I think, madam, that is all. But there's anything, we'll definitely come back to you.
Yeah, I hope I was quite informative.
Absolutely, madam. Absolutely. It was a lovely session, like every time. Yeah.
Because PCOS is such a vast this,
I
and
know.
and the individuals that we come across is also different. Each individual needs a customized treatment.
Correct.
Counseling goes a long way, and I would say all my colleagues that history, physical appearance, counseling, making them understand, and referring them to the right people makes a lot of a difference in the treatment profile.
Yes, one very important point you made, making them realize the importance of proper lifestyle and, sticking to discipline.
Yeah, as I said that, if you have a 15-year or you have a person who's working in the media, or you have a lawyer, I had a corporate lawyer who worked for the European country. Okay. Now, for them, they were working late hours because they had to work for the European country. How do I tell her that, your job profile, you need to change your job? So we have to try to stick them in their profile.
Correct.
So
That's correct. Yeah. Thanks once again. It was a
thank you,
session.
Hetero. Thank you for
it was a pleasure.
It was a very
Ma'am, can I ask one question?
Yes, please.
Ma'am, PCOS, sometimes the ovarian volume is normal. Still, it is on the clinical history, they say it is that. So how do we go about it? Rather thin PCOS.
Yeah. So when we look at the Rotterdam criteria, we are not looking only at the ovary, but an overall. So the menstrual history is very important. Amenorrhea, oligoanovulation, anovulation, and the hirsutism acne. Now, in a patient who has a good volume, But these changes, she still comes under PCOS. And it is not that every PCOS does not get pregnant. There are quite a few numbers who get pregnant on their own. So these are the patients who would probably get pregnant on their own because they are ovulating. But they're the pattern. So the criteria goes that any two of them should be present. It is not just a morphological look.
But for the thin PCOS, when we start the hormone therapy,
Yeah.
so when do we stop for them to conceive?
So when we look at the hormone therapy, we give a short protocol to them. Probably a 3 to 4 cycles is what we give them. And then we ask them to follow up. So basically what we do is we are trying to change the androgenic environment in the ovary, and then we try to stimulate them. So the whole role of myoinositol in fertility is starting them at the right time. So as you start, we don't get the response. It takes 2-3 months because you're first changing the metabolic picture in their body. And that is when things reverse.
So either myoinositol, the dose is right, or it requires still higher dosage, the concentration?
No, this is 4 grams is what is the dose that is required. And their physiological ratio is very important.
Thank you, ma'am. Thank you.
Thank you, madam. Thank you so much.
Yeah. Thank
Thanks,
you so
Vijay.
much.
Yes.
Yeah, thank you so much. Thank you, Priya. It was wonderful to connect with all of you all. And I hope this awareness and this program can help all of us. I'm also learning with these sessions.
Thank you so much, ma'am, for being a speaker with us. I still remember the first time I met you, you had given me a live prescription of Myotin. And thanks a lot for coming, for sharing your valuable knowledge. Today, I have learned so much from you about PCOS, and I still think there's so much more to learn.
More to learn.
Yes, there is no end to knowledge. And not just, I salute you for your technical and your medical knowledge, but even your communication is excellent. The way you communicate, the way you try to explain everything is highly motivating and very encouraging and very nice and very positive and loud and audible. So it was a brilliant presentation. Thank you so much, ma'am, for being with us, and please be connected with Hetero for your lifetime. Thanks a lot. Thank you so much, Dr. Khande Parkar, for being with us. And thanks for all the mediation, the question answers, introduction, and thanks for being with us. I also thank the entire, all the doctors who have come here, removed their time. I've attended this webinar. I thank them so much, because I know in time is money. And at this time, it must be very, very difficult for you, but you still made it. I thank the entire Hetero staff, sales, marketing, everybody for being a part of this webinar. Thank you so much. And I'm looking forward to have more such exciting webinars in future. Thanks a lot.
Thank you. Thank you, everybody. And have a good evening.
Thanks a lot. Yeah. So I think we can log out now.
Yeah. Thank you very much. And let us connect in the right ways.
Absolutely. Thanks a lot. I'm looking forward to meet you again, ma'am. Thank you so much.
Okay, Dr. Prashant, thank you so much.
Thank you so much.
Thanks for the questions. We are all learning. And I think every day we come across new things, and that makes us